Hello everybody and welcome to the Tuesday edition of Video Clips. And so first thing, a couple of free things coming up. On October 3rd, you get to spend, if you want to, an hour on the phone with Dr. Kathy Waller, who is the author and designer of our vaccine education program. I'm going to interview her a little bit. We'll have a little bit of Q&A at the end. She's a very busy woman and you can take the whole course if you want to, but this is an opportunity to hear some basic stuff from her about vaccines that I think you'll find really interesting. So if you want to register for that workshop, I'll tell you how to do that before we're finished here. So that's October 3rd. October 4th is our next free dinner, and wherever you're watching this from, I can't feed you if you're not in Central Ohio, but what I can do is let you see the workshop, which I've changed it up a little bit if you watched it before, and do some Q&A at the end of the workshop. And you can ask questions. We always have somebody who takes email from the distance audience, and you're welcome to ask me questions about what you hear. So that's October 4th. And then, I cannot believe I'm saying this, but we're only 6 weeks away from our conference on November 4th through 6th here in Columbus. Our guest speakers are the best of the best of the best. We're talking about Dr. Peter Breggin, the psychiatrist from New York. We're talking about Dr. T. Colin Campbell, author of China Study. Neil Barnard from the Physicians Committee for Responsible Medicine. Thomas Seyfried, who wrote Cancer is a Metabolic Disease. Dr. Marielle von Lanthen, Dr. Janice Taylor. I mean, the list goes on, and they are all amazing speakers. Your conference ticket includes your meals, and the food is amazing. Our wonderful chef Del has taught the hotel how to make fabulous food for us. So anyway, you do not want to miss it. All right, so today we're going to relate to you some highlights from an interview. Laura Esserman is head of a breast cancer care center at the University of California, San Francisco. She was interviewed by Eric Topol, editor-in-chief of Medscape, about cancer screening and cancer treatment, and she shares a lot of my ideas, so I thought her perspective was great. So first, Esserman says, cancer is not one disease, but it's several, and much of what we call cancer really isn't cancer at all. And she talks about ductal carcinoma in situ, which is a disease, Esserman says, that was actually created through screening. And one of the problems with screening is that the original hypothesis upon which it was based at the time it was instituted was wrong. So this impacts breast cancer, it impacts prostate cancer, colon cancer, cervical cancer, lung cancer, many different types of cancer. Now, according to Esserman, in the 70s and 80s, medical doctors were looking at, from a population standpoint, people who had stage 3 and 4 cancers had much higher death rates, of course, than people who had stage 1. So the assumption about the benefits of population screening were that if you caught everything early, you treat people and they would never progress to stage 3 and 4 cancer. Now, the underlying error, the problem was that the assumption is that cancer is just one disease, which it isn't. There's a whole range in the seriousness of cancer that goes from what we call indolent, never going to cause a problem, and Gilbert Welch refers to this as pseudo-cancer. I mean, it may have some properties of cancer, but it really isn't cancer, all the way to something that is aggressive and potentially fatal. Esserman says what happens is we treat the people who don't have very serious cancer aggressively as if they had cancer, and she said we've never been able to help somebody who really has serious cancer by over-treating somebody who has less serious cancer. So the assumption was we catch it early and treat it before it advanced, and that's just not what's happening. Because most DCIS, ductal carcinoma, is indolent, Esserman proposes that we rename it. And her proposed name is IDLE, or indolent lesions of epithelial origin. Now the reason this actually makes a lot of sense, because with certain types of thyroid cancer and also with cervical cancer, when you get rid of carcinoma, cancer, when you take those terms out, the emotional charge is gone, and then both doctors and patients aren't so anxious to do something about it. So for example, the precursor to cervical cancer used to be called cervical carcinoma in situ, and at that point in time it got treated like cervical cancer. When it was renamed cervical intraepithelial neoplasia, or CIN, it doesn't sound as aggressive, and as a result it's often treated by watchful waiting, because it's well known that about 50% of the time it just resolves. And it doesn't resolve just because people are eating well and that sort of thing. This is in general population who do nothing, don't change their diet, nothing changes. They just go home and continue to do what they were doing before, and it goes away. You can almost be certain that it'll go away if you change your habits and do the right things. In the case of DCIS, Esserman says we should just look at it as another risk factor for cancer. We don't know if it'll progress, but instead of treating it, she says we might want to look at evaluating the totality of a woman's health. I mean, is this person at high risk for other reasons? Looking at strategies to reduce risk. Oh my gosh, maybe changing the diet in order to prevent it from becoming cancer. Investing in research to determine who actually is at risk and investigating alternative therapies. She questions why the medical profession is so willing to recommend interventions without evidence that they're effective. And my gosh, I've been questioning that for years. It doesn't really matter what articles get published or how bad the data are. We just keep doing the same thing over and over again. And so Esserman says aggressive treatment for DCIS doesn't improve outcomes for patients. For example, radiation doesn't reduce mortality. And she says even a patient with invasive DCIS that's strongly hormone positive will not benefit from radiation treatment, adding, quote, "Why would you do that?" Well, I ask that in these video clips almost every week. Why are we doing this, and when is it going to stop? Now, Esserman cautions that we shouldn't throw the baby out with the bathwater, and I agree with this. While most women don't benefit from mammography, research is currently looking at which populations of women might benefit. Screening is not the problem. The problem is when we take something that may be beneficial to a small part of the population and then we try to make it available to everybody in the population. That is where the problem is. It's screening everybody in the same way. Considering multiple factors like health status, genetic profile, breast density, we might be able to determine certain segments of the population who would benefit. And at one point in time, before we had MRI technology that was so good, it was a decent diagnostic tool. It's just never proven to be a good population screening tool. She says that we really have to do something different. I mean, subjecting all women to the same test on the same time schedule hasn't changed anything. We still have 40,000 women a year who are dying of breast cancer. And by the way, women with breast cancer don't necessarily like the treatments that are being offered to them. And if we just keep doing the same thing, we're going to keep getting the same results. Like Gilbert Welch, she says more is not better. She cited a study that was done in Europe with women who have a gene mutation that really doesn't put them at much higher risk. And survivors in the group without, or survival in the group that has chemotherapy is 94.7%, and it's 92.5% in the group of breast cancer patients who don't have chemotherapy. Remember, we're talking about a 2% advantage and a drug regimen that has some fairly serious side effects. And she says one of the problems is that when women get cancer, they tend to forget all logic. They're operating on a highly emotional level, which is certainly understandable. And without taking the time to calm down, they tend to just do what their doctors say. And doctors, of course, are always going to be fans of more aggressive treatment, or at least most of them are. And so you end up with overtreatment with questionable benefit. Furthermore, she says medicine tends to stick with the current paradigm that if A is better than B, we should always do A. Well, on the surface that sounds good, but what if A is only a little bit better than B and B is not as toxic as A? Is A really a better choice? Well, maybe some more judgment and discernment is needed. That's something I've been talking about a lot. It all sounds well and good that there's a tendency to want to standardize medicine in the United States. Because it's another one of those assumptions, like the one underlying cancer screening, that just isn't right. The assumption is that if you standardize everything, what will happen is really good protocols will become the standard of care, and doctors won't mess up because they just automatically do the thing on the list that everybody does. Well, what happens when you take clinical judgment out of the picture is not very good stuff. I mean, doctors spend a lot of time in school. They spend a small fortune to educate themselves so that they do have clinical judgment, the good ones anyway. And trying to train that out of them, actually not such a good idea. So when will this change? Well, she says a major barrier is the fear that many physicians will be liable if the patient has a recurrence after less aggressive treatment. Now, she says, first of all, there is no way to prevent all bad things from happening, and I will say I'm convinced that at some point in time, somebody's going to file a lawsuit against a physician for overdiagnosing and overtreatment. But the risk of having bad things happen can be mitigated somewhat by having different kinds of conversations, and she describes what essentially is informed decision-making with patients. She said that when a patient declines a particular treatment, she doesn't say that the person refused to do it. She says basically the patient was informed about the available options. And she says it's really important for patients to choose the things that they know are beneficial for them rather than choosing something just to please a doctor. Esserman emphasizes the need to that we have more research, questioning why we argue about data that are 40 years old. And I agree, there's so much new information that is available, and we know for a fact that population screening is not reducing the death rate from most types of cancer. So we have a lot of good data we can look at, but we need new research also. And what should happen is the model changes and morphs as more information is gleaned. And hopefully we could answer some questions like, who does benefit from mammography? The whole population of women doesn't, but maybe there are some women who do. Who benefits from chemotherapy? Maybe even though from a population standpoint you only get a 2% advantage if you have women with a certain gene mutation getting chemotherapy, but maybe within that population is a very small number of people who actually do benefit. So that's what we should be looking for. And there's this tendency to be at polar opposites. We're either going to do everything the same way to everybody regardless, and the results are disastrous, or else we're just not going to do anything at all, and I don't think anybody feels comfortable not doing anything at all. She says at the end of her interview, she said, I'm clearly passionate about what I do, and she said people should want their doctors to be passionate, and I think that's certainly true. There are plenty of good, passionate doctors out there. I mean, I'm going to record a workshop this week for how to find a good doctor to put on our member site, and they are out there. You just have to go looking for them. She says she's known as a rebel, and she thinks that's a title that she likes and she's earned. And I guess if all doctors were patient-centered like this woman is and interested in helping patients to make informed choices, first of all, I agree with her. I think that the liability issue would somewhat go away. I read a book long time ago written by Malcolm Gladwell. I've read all of his books, by the way. This book was called Blink, and it's about how people make first impressions about things, or develop first impressions about things, whether it's a person they meet or a television show they see for the first time it's aired, or a product. And some of the data in the book were about malpractice insurance, malpractice claims against doctors. And Gladwell says that people do not sue doctors who make mistakes if they like them. And they tend to sue doctors who didn't make mistakes because they don't like them. And we all know that one of the reasons why people don't like doctors is because sometimes they're arrogant and distant and they're not very interested in collaborating with their patients. And so I don't think you can ever do anything that removes all liability, but I think changing the relationship between doctor and patient, not just the demeanor of it, but what's discussed, would go a long way in helping with that. So anyway, that's all for today. As usual, pass this on to anybody who you think would enjoy watching it. And if you want to sign up for those workshops I talked about earlier, Pam Popper at msn.com. Pam Popper at msn.com. How could I forget my email? I use it 2 million times a day. So anyway, be back to you on Thursday with more news.